Muy buenos días, muy buenas tardes, muy buenas noches. Les doy la bienvenida a todas las personas que nos acompañan en el webinar 126 que el Organismo Andino de Salud, Convenio Hipólito Unanue, inició el ciclo de seminarios web en mayo de 2020.
A cycle of webinars in May 2020. We celebrate the 50 years of Horas CONU, of uninterrupted work of joint and articulated actions with the Ministries of Health with the 6 member countries, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela, with the vision of advancing in the guarantee and the right of health for everyone. Let's remember that the pandemic of COVID-19 is not over, and the vaccination strategy against COVID-19 is safe and effective to protect others. The more people we are immunized, the lower the probability of becoming infected, in addition to the protection that we received against the severe forms of the disease. Make sure you complete your vaccination schedule. There are no excuses not to get the vaccine against COVID-19. Also, don't forget to comply with the non-pharmacological preventive measures, such as the use of masks and constant hand washing. Today, Thursday, June 16, 2022, we begin this virtual meeting with the aim of learning about the current status of monkeypox around the world, as well as the progress of measures for its prevention and treatment. We invite you to leave us your name, your organization, and from which country you are joining us in the comment box of the Facebook Live or YouTube Live chat. In that same space, you can leave your questions or send them both through the email webinarhorascono@gmail.com. It is extremely important to mention that to facilitate the access of this seminar for the English-speaking community, we have a YouTube channel that is providing simultaneous translation into English. In this webinar, dear participants, we will follow the usual dynamic. We will start with the institutional greeting. After it, we will have the presentations from our speakers, then the active pause to move to the question and answers space. To access the attendance certificate in any of the Facebook Live or YouTube Live chats, you will find a fixed link. You must fill out a brief survey and then leave your data for the issuance of the attendance certificate that you will receive during the next week into your emails. To begin this important day, I would like to introduce Dr. María del Carmen Calle Dávila, Executive Secretary of the Andean Health Organization, Hipólito Unanue Agreement, who will give the opening remarks. Please go ahead, Dr. Calle. Thank you so much, Lucho. During the last 30 years, many events were established due to emergent infectious diseases. Those who were not familiar with the source, and they are extended geographically among different individuals and wild and domestic animals. Many of these diseases are called zoonotic, that are transmitted when the humans are invading rural areas or wildlife exposure for selling these species into markets, bringing these animals into the rural areas. Currently, we have an additional severe factors for the extension of these diseases. Climate change is affecting the natural areas for these species. Well, global warming is generating dry seasons, forcing those animals to displace from their natural areas, increasing the risk of contagious with human species, and having this greater risk of cross contamination for animals to humans and to humans to animals. So other factors that will contribute to these diseases will be civil wars, the human growth and plant migrations, and urbanistic deterioration, and others. The most impoverished populations are the most vulnerable for the presentation of these diseases, and among them, the unattended diseases. More than 30 microorganisms were detected during these last couple of decades, where we find HIV, Escherichia coli O157H7, the Ebola virus, several types of hepatitis, influenza, Rickettsia feli, the Nile Occidental disease, many beta coronavirus, among them SARS, MERS, and SARS-CoV-2. Monkeypox was a disease that moved from 11 endemic countries to non-endemic countries with a total of 1,600 cases. So at this time, the IHR expert committee is evaluating the possibility to determine a new public health emergency of international concern. Today, we have the honor of having Dr. Eduardo Gotuso Herencia. He is a pretty well-known colleague that will talk about the current world situation of this condition. Thank you so much for being here. I'm sure that this webinar will contribute to the knowledge, to the evidence-based knowledge that is so important for the decision making into these uncertain times. Please, Dr. Gotuso, you can share your screen.
Lucho, no se te escucha. Lucho, no se está escuchando.
Muchas gracias, doctora María del Carmen Calle, por su saludo, cordial saludo.
Thank you, Dr. Calle, for this introduction. I am Luis Bengolea, epidemiologist, and I work in the area of borders and other areas of the Andean Organization of Health. I will be in charge of the moderation of this webinar. So after this introduction, I would like to welcome Dr. Eduardo Gotuso Herencia. He's a physician, master from the Cayetano Heredia University, specialist in epidemiology and internal medicine. He directs several projects with international support that allow dozens of young students to investigate. He was the first Peruvian physician to become president of the International Association of Infectious Diseases. He is a joint professor at the William J. Harrington Training Program for Latin American at the University of Miami, the International Department of Health of the Johns Hopkins University, and also from the University of Alabama in Birmingham in the US. Today, he is the main professor of the Cayetano Heredia University School of Medicine, head of the Department of Infection and Tropical Diseases and the university, and director of the Alexander von Humboldt Institute of Tropical Medicine. He contributed to different chapters and books in Peru, the US, Latin America, and the Caribbean. He had published 2 books and 6 manuals. He is considered an emeritus professor of the University Cayetano Heredia and is a main professor of the medical school of this same university. head of the Department of Tropical Diseases, and has contributed to many healthcare initiatives and the Ministry of Health. Please, Dr. Eduardo, the space is yours.
Sí, muy buenos días y muy buenas tardes.
Good morning, good afternoon, depending on when you are. Thank you, Dr. Bengolea, Dr. Calle, for your kind introduction. I would like to thank the opportunity of sharing this lecture about this new situation that has appeared in the world, and it's quite concerning for our nations. The objective of this presentation is to review with you the data we have regarding what are the perspectives that we can implement in each one of these conditions. The first thing that we have to remember is that we have to remember that this is a very old disease. Actually, the first one that was eradicated through vaccination, that was human smallpox. This is a condition that was eradicated 42 years ago. We stopped implementing vaccination strategies because this condition caused a mortality rate of 3 to 25%. In Peru, of course, it was not the exception of this situation. And Peru produced vaccines for this smallpox, and we were considered a reference source for Arabic countries, for example, to produce vaccination against smallpox. And from the 80s, we stopped vaccinating. Even in the story of Peru, as other areas of the Andean areas, in Inca Empire, it was like some reports about health conditions or health wars, because one of the Capac brothers was murdered or was infected with this disease, and unfortunately he died. And there are some stories about this condition that affected the Inca Empire. Dr. Uriel Garcia, for example, wrote a book about this genocide that it was experienced. Also in North America, the English fellows affected some other populations using the smallpox as a weapon. And this little girl has a condition, and this was the last case on the world having a disseminated presentation of the disease. And from that time, we have very few cases on the lab where we have accidental contamination. And we know about two situations that the smallpox virus is stored in two areas secured by the United Nations in the US and Russia. So these are stored virus for potential future use. We know that some countries have this virus stored to protect themselves against the potential biological war. The monkeypox, of course, is related with the forest areas in Africa and Congo. They wanted to change this name due to the stigma that is related with the African countries. This is a zoonotic condition that affects the human being. We have right now 11 endemic countries in Central and Western Africa, with Nigeria and the Republic of Congo as the most affected countries in terms of prevalence and incidence. It's considered an endemic condition due to the use of some animals into different purposes for them, and that's why we consider a mortality rate on those countries of 4.7%. They have some minor numbers some years back, but for the year 2022, in Nigeria, for example, we have 110 cases and with only one deceased. And that's why we would like to highlight those numbers. In Cameroon, we have 28 cases, 2 of them passed away. In the Republic of Congo, 7 cases, 3 of them died. So the visibility of the condition might be quite rare, and that's what happens in our countries with yellow fever, because we only report those severe cases. The very mild or moderate conditions are not reported. So it's important to highlight that in the African areas, the transmission between human to human is quite infrequent. It's not referred. The transmission from human to human, it's a zoonotic disease that comes from the animal to the human being. So one important fact is that the monkeys are not the reservoir. It's actually the animals that are affected by the virus. The main affected animals with this condition are the rodents. So in those areas outside the African continent, we had an outbreak in the US in 2003, and in that particular situation, we don't had a report of contagious from human to human, but we have actually the infection by that very small animals that are called and Dr. Calle mentioned that this is a quite emergent condition because it appeared in the moment that I finished my review of this case. We have more than 31 countries that were involved with the monkeypox. In only the last 6 weeks, we have 55 of these patients that were hospitalized, but they were hospitalized basically to take care of them or to isolate them, but not because of the severity of the condition. So surprisingly, we don't have any single case that is reported as a fatality condition. And it was demonstrated that the genomic information that we had is actually the genomic information that comes from Nigeria. And that's why it's so important to have the information that I mentioned before, because in the Republic of Congo, the genome have a higher mortality rate, while the Nigerian version had a mortality rate below 1%. So it's a very important aspect for the decision making. We have this new condition with a known virus that have a mortality rate that is so variable. It's important to know which is the source that virus comes from. Another important component is that when we define the classic model of what a smallpox or the monkeypox, this is actually a condition that comes from the reservoirs. Many times they are hunted or used as pets on the houses. So this might be considered the reservoirs. We are considering some different rodents, such as squirrels, prairie dogs, dormouse, and the monkeys are not reservoirs, but are a source of contagion when they get sick and they have these lesions on the skin, and these skin lesions are extremely contagious. So it's important to mention that in the monkeypox, the monkeys by themselves are not the reservoirs, but these rodents. The gorillas, for example, experience the disease in a similar manner that the human beings suffered this condition, but they are not considered reservoirs. So it's extremely rare to have a condition that comes from human to another human. And we have some extent reports about this spreading profile of this particular condition. And it's very important to consider the clinic. It's a condition that appears as any other infectious disease with fever, muscle pain, headache, and also chills and exhaustion. And many clinicians might confuse it with dengue or chikungunya. And we start to see after 1 to 5 days eruptions on the face and start to expand. They start on the face and they start growing on other parts of the body. The second component that will help us to make a differential diagnosis with the classic smallpox is that in the monkeypox, we have lymphadenopathy in the neck and the armpits. We start to feel some growth and edema on the in the lymph nodes, and that's another clinic sign that will help us to differentiate between the classic smallpox and the monkeypox. Another component that will help us to make a differential diagnosis with other conditions is that the early eruption is quite early and all the lesions are in the same stage. What happens with smallpox is that you have these little lesions on the face, but they are like dry face, or in some other areas we have already the scars. So we have several stages, and pediatricians are quite familiar with this course of the disease, different levels of eruptions. So it's an important factor to consider is that we start to see different maculas, papulas, vesicles, and pustules that are the dry lesions in the case of smallpox. So to understand the inflammatory lymphadenopathy might help us to differentiate from the smallpox virus. This is not a human smallpox, but a clinical course of monkeypox. Another component that we might use with this publication, with this international publication, show the different stages. And here you see the ones that are progressing a little pustule, and then we have an umbilicated pustule, and then it ulcerated. Then we have the crusting of the mature lesion, and finally partially removed the scar. We don't see all the lesions or the different stages in the same patient, but we have all the lesions in the entire body with the same stage. When we have the crusting stage, we will see all these scars around the body. And this is an important component to analyze in the skin examination. Of course, there are a few exceptions, but the clinician has to apply the clinical judgment of what they found in a more regular basis. So apart from that, in this new outbreak, we have some different aspects that we have to take into account. The first different condition is that the vast majority of patients recognize that we have actually a human-to-human transmission. Basically, that was reported in men that had sex with men. Is actually very few cases of women affected. So this is the higher risk that we have to determine. We don't know if this is true to intercourse. We are looking for the virus. We found fragments of the virus in the semen, but it's not isolated yet. But in a man-to-man relation, in a close relation where men have a lot of hair, it's easy to have small wounds that are shared or moved to transfer to the other individual. And we are talking about this high risk population, but it's not defined yet as a sexually transmitted disease. That's why the lesions are diagnosed in dermatological offices or areas where sexual conditions are detected. The vast majority of patients were diagnosed in the dermatological office or in the sexually transmitted disease experts. Another important consideration is that the lesions could appear in the genitalia much before than in the face, something that doesn't happen with the smallpox. So this is an important concept that we have to take into account because we have to suspect about this consideration when we found it. The third or the fourth difference is that this is a different genomic that comes from Nigeria. And the mortality rate, as I mentioned before, is 1%. However, up to this day, when we have 1,013,100 cases, we didn't have any report of in different conditions. They have to be considered, but the virus that comes from the Republic of the Congo, not from the Republic of Congo, but is associated with a higher mortality rate. So these are things, there are new things that we have to take into account or take into consideration. For example, this one that comes as an atypical lesion that was described in Canada. You see here all these lesions that are in the same stage but around the genitalia. So surprisingly, this patient didn't present fever. The clinicians suspect that it was during the early stages. They studied this patient that was described as an early condition, might be herpes or condyloma, or they were suspecting about syphilis, but it's important to suspect about this kind of lesions. And in this particular situation, we didn't have fever, so the fever was actually a condition that might be absent in those conditions. It's important to highlight that in the year 2018, the group of Nigeria, they review very carefully their experience in a university hospital, and it turned out that they published in PLOS ONE this information. In this research article, they recognized that they had this typical set of lesions around the same stage. You can see here that they are not in scaring phase, but they are all evolving in parallel. And the second component that we have to take into account is that they were male. The vast majority of cases were detected on men. They were hunters that go to the jungle area, and here they have a contact between men to men and also sexual relation. And this is something that was recognized in Nigeria, recognizing this condition. From the 21 cases, they all have cutaneous lesions, fever, a lot of symptoms. 13 from 21, they have severe stages of ganglia, and they have also genital lesions. 10 from 21. The vast majority of patients from this series, they have this consideration. So it seems like in Nigeria, and they start recognizing this this background, the contact from human to human, something that was not recognized from the Republic of Congo, and it was a clear zoonotic spreading. So as you can see in these pictures, it looks like a smallpox, but it's not a so severe condition. All the lesions, as I mentioned before, are in the same stage, and I think that from the clinical perspective, these pictures should be considered a reference. The vast majority of people are not exposed to this presentation, but it's important to consider these aspects. So the first question is, what is the differential diagnosis? The differential diagnosis is quite important in terms of the sexually transmitted diseases, because the groups that are getting infected, as I mentioned before, are men who had sex with men. The three most recognized sources that were detected in Canada, in Spain, Portugal, and the Canary Islands are related to festivals of the gay community or these zonas that are considered centers of sexual activity. And it's important to mention that it's important to train this population without this, generating a stigma. It's important to recognize the rights of all the human beings with independent from their sexual activity. But when we see this type of lesion, of course, it's not a lesion, a typical lesion. We can have a differential diagnosis with disseminated herpes, disseminated lesions in the palms of the hand or in the plants of the feet with similar lesions to herpes. So basically, we can try to find or suspect about this type of sexually transmitted diseases. Actually, when this group, additional from the monkey virus, they have sexually transmitted diseases. We have also comorbidities within these groups. So we need to remember that it's not only in the US, the entire American continent, we have exponential growth of syphilis. And during the pandemic, one of the most important findings in the list of diseases is the progressive activation of syphilis due to the fact that we don't have control. The COVID pandemic left behind other conditions, hypertension, diabetes, regular vaccination for small kids. But one of the important components that was left behind was controlling pregnant women that goes to the delivery room with syphilis, something that wouldn't happen. And we now see many cases of congenital syphilis because this disease was uncontrolled, especially in men. And unfortunately, the people with HIV, due to the fact that they don't have a detectable virus, stop protecting themselves, and they have a very intense sexual activity that start spreading the virus. So as I mentioned in the previous picture of the 3 cases of differential diagnosis, we have to clearly recognize that we have less and less smallpox in the country. We don't have the information from other countries. I apologize for that. But this is the information we have in Peru in terms of the disappearance of smallpox. We see how during the last years, due to the vaccination programs we don't have reports of smallpox. Another aspect that we have to consider is the treatment. Do we have a treatment for that virus? We don't have a defined treatment. Actually, up to now, we don't. We only know that we have to follow the patient with a clinical support. There are some drugs that were approved for the human smallpox. The FDA and the EMA from Europe have approved pharmaceutical products that were approved for human smallpox, but due to the fact that they are not used yet for the monkeypox, there's not enough information. Many drugs has been studied that are matter of new studies where we showed how these drugs moved to animal experiments. In the case of CD4 that was used for cytomegalovirus, systemic or eye presence of cytomegalovirus, have several results, and we found similar drugs like brincidofovir, but in animal studies, we have very small, limited results, especially the one that was produced in England with patients with the monkeypox. We had a lot of toxicity, and we have this eruption uncontrolled. And you will see that there's a condition with cidofovir, a drug that could be useful, but up to this moment, we don't have clinical trials. We don't have very reliable information about these active principles. We only have information that come from animal studies. But due to strategic measures, the FDA and the EMA approved this drug for human smallpox due to the possibility of having a bioterrorism attack with this strain. So the next question we have is, well, so we have vaccines. Actually, we have 3 generations of vaccines. The ones that were lyophilized and kept in our storage areas that we received when we were kids, that we stored for a potential attack of human smallpox. But we see how a 2nd generation was created, and now a 3rd generation of vaccines are appearing, but we don't have many studies. It's important to mention that from the real perspective, we have a vaccine that is the most popular, that has three names. This is the name that is used in the US, the name used in Canada, and the name used in European countries, that was approved for two conditions: for close contact with patients or lab staff that work with this virus. This is a non-replicant vaccination virus that will be the most interesting option with lower toxicity. So this is what we have. But how much vaccines do we have? In Europe, we have places where the WHO have 1 million doses. And imagine that you will need 2 doses apart from each other in 3 or 4 weeks. It will be 500,000 individuals. And of course, we wouldn't have enough vaccines for the entire continent. We have another aspect that is the attenuated living virus that have some restrictions, for example, immunosuppressed patients, and also have very concerning toxicity. It's not an easily implementing vaccine as others, because in front of an emergency, we have to think about the risk against other components. And an important consideration is that we are not going to make a massive vaccination strategy. Those vaccines are not for general population because the possibility of this process to spread is quite minimal. And this is an important concept to keep in mind. Another important concept that we have to take into account is that for the first time, the elderly, we have some advantages. We recognized some years back when we have the Asian flu in 1957, with those who were born before the 57, we have the proper antibodies. So people older than 57 in Peru and the entire region of the Latin American countries, we might be protected up to 85% or more, because we have those antibodies that are protecting against this monkeypox. I recall that we were vaccinated as soon as we get to school. I remember my first day in the primary school, and everyone were going through this vaccination process, and it was quite interesting because the smallpox disappeared, and 50 years later we discovered that we are already protected against this new strain. And this is something that is quite important to the epidemiologists and the ones who are in charge of epidemiological surveillance. And we don't know what will happen with those elderly patients that are suffering from immunosuppressing condition or neoplastic diseases. It's important to have an active surveillance strategy. This is a publication that came out in May by the CDC about who are the ones that might receive a vaccine. The ones that need it the most are the occupational risks, so those who work with this virus in labs. And it's important to know what do we offer, or what are the vaccines that are available. It's quite important to recognize who will be in charge of prioritizing the vaccination. I'm sure that we have to provide a booster depending on the type of vaccine. The ACAM every 3 years and the Gineos every 2 years, with a reinforcement or the reboost after 10 years. And it's important to know that this is a replication virus. We can have accident of, there are some secondary effects or adverse effects. We have 6 for every 1,000 vaccinated with myopericarditis. So in COVID, it's 10 for every 10 million vaccinated. So see that it's a very infrequent condition, but it happens, and it's important to valorate the risk. So from the practical point of view, the risk might be smaller. They also published this list of the ones that are not candidates for this condition. The contraindication with Jynneos is only suggested for those serious allergic patients, but when we analyze the contacts, family contacts, or close contacts have this contraindication that is not extreme contraindication, but have to be assessed by their physicians. Additionally, from that, the WHO, from the publication that was launched a couple of days ago, recognized that we have to put what we call the high risk, medium risk, and low risk populations. The general population has a very low risk, so this is not a condition that needs a massive vaccinating strategy. So we need to take into account what will happen with the lab professionals, the healthcare professionals, that might be informed about the fact that this is a classification that allow us to know who are the priority groups under this condition. Another component to take into account is what the Charles III protocol, but it's quite easy to read, and also the two communication that came out from the WHO. So the golden question is, do we need to declare a pandemic? The majority of experts are convinced that it's not too late. We can revert this outbreak. We have some opportunities. The mechanisms of contain the feasibility of infection is not that high. So the possibility of a pandemic will have a very low probability. It's of course an outbreak, and we have some cases in Brazil and in Australia and Mexico, 5 or 6 cases. We all have the same exposure. People that travel, that were in communities where we have relations between men. And of course, the pattern is quite clear. The number of women that are infected is quite small. There are very few cases, and there are very limited information about these women. A very few weeks ago, an author wrote some words about how positive we need to be in this current situation due to the mortality rate, the transmission of a known condition. And we can analyze the groups. Today, the labs are able to detect quite quickly the spreading patterns, and our Institute of Health are capable of distribute vaccines, but unfortunately we don't have the vaccines available. Imagine to produce 10 millions, it will be a problem, but producing 1,000 million will be an extreme problem. So we need to keep in mind that the selective vaccination strategy might be the way forward. And even though we know that these are effective in animal models, we don't have clinical trials that will show the effective vaccines, so we might return to the endemic areas, Nigeria or the Republic of Congo, and participate in research projects that will help us to assess. We have a proper evolution, and we have part of the population above older than 57 years that will be already protected. It's important to measure the impact or the evidence behind this condition. Many countries are scaring the population because they are informing or reporting this condition as a new COVID, and of course the condition is completely different. In second aspect, we need to make a strategy to the pre-exposed individuals, to the health staff that are in emergencies or see countries that are affected after the exposure. So here we have a very important component to take into account. There are some expert groups that have to be consulted. The fourth component is that we have to strengthen our surveillance strategy to monitor epidemiologically and biologically every single country. Today we have experts of genomic in every single country with labs that will be able to determine the epidemiological pattern, something that the COVID-19 pandemic thought is that we have to strengthen our labs and the monitoring have to be efficient, also together with an efficient production of vaccines, having the vaccines available. And it's important to have the politicians that have to accept the recommendation from the experts. What was our main mistake during the pandemic? Unfortunately, the politicians were involved into the scientific activity without respecting the recommendations from scientific experts. So they use some claims to do political campaigns. So the leaders have to trust in their experts, trusting on the data, accepting the strategic plans with scientific information. And I think that this is the great message that we have to share with our peers. So we need to train our health professionals so the diagnosis is there in different health centers. So these clinical findings will support us to analyze the pattern of the lesions that could appear in the genitalia, on the face, that disseminated. There are mainly manifest as a cutaneous condition. It's very similar to infectious mononucleosis. We have to monitor the high-risk population. And remember that we are discussing with the WHO to change the name of monkeypox because they are stigmatizing the African countries. And the risk individuals that could be another different group need to be educated, accepting the information that they receive without suffering stigma. I am a defender of the LGBTI communities. We have to respect the sexual orientation. We don't need to stigmatize or make a moral accusation about their behaviors, but to supervise and to advise the risk behaviors. And as I mentioned with Dr. Calle, we have a regional need to strengthen the work of the primary healthcare providers. So these primary healthcare providers will help us to establish a regional front, keeping our attention in terms of we are dealing with a new disease, but now the attention of the population needs to be concentrated in the vaccination strategy so we can reduce the occupation by COVID and trying to return to those vaccination coverage for those children that are not vaccinated against smallpox, against hepatitis, neoplastic conditions that are not treated, diabetic patients that are not receiving their drugs. So the world have to come back without losing sight of what is a priority. Today, our three most important priorities is to strengthen the health systems and to finish the vaccination with 3 doses in every single group. And those risky groups should receive the 4th booster, trying to vaccinate our entire countries in the Andean region. So this will be the summary that I wanted to share with you. I would like to thank Dr. Carlos Medina from the Cayetano Heredia University in the institute that we work with for his support, and to Dr. Carmen Calle and Dr. Bengolea for allowing me to share this lecture with you. If you have any question, please feel free to ask me. I will be happy to share my answers. And in case that I don't know the answer, I promise you that I will look for it. And we need to make decisions based on evidence. And if we don't have the evidence, we need to create it. And it's important to encourage the politicians to receive with open arms the advice that come from experts. Thank you so much, Dr. Eduardo, for your brilliant presentation. And I would like to highlight that the topic that you just covered is extremely important for our health authorities. And as you mentioned, will help us to prioritize our fight against COVID-19 so we can have an effective control in the most vulnerable groups. During your presentation, I see that is quite relevant. They have the fact of being guided on how to respond to this new problem produced with this virus. A virus that is characterized by some aspects because within the many variants, the world now has the possibility of, even though being affected, it's less concerned than the previous COVID pandemic, and also less impactful than other viruses, at least the ones who arrived to the Latin American region. We are dealing with the Nigerian version. We know that smallpox has been eradicated, but during the arrival of the Spaniards, they were used as biological weapons unconsciously, but in the Inca Empire as well. And maybe the same happened in the Azteca or Maya Empire in the area of the Yucatan Peninsula. So this is something that is related with the fact that smallpox, the human smallpox, was extinguished in 1973, and from that year, or actually from 1980, we do not vaccinate our children against this condition. But it's important to highlight that the human groups, elderly patients or elderly individuals, have the possibility that having antibodies produced by the vaccine that was applied some years back, the younger populations maybe are not that protected. So this monkeypox specifically was missed call because the reservoirs are actually disseminated in different rodents in wildlife settings. Rodents such as squirrels, they use it as a pet, and that's why in 2003 we have an outbreak of endemic areas of the prairie dog. So the message makes us reflect about this problem is extended in non-endemic countries, having into consideration two aspects. The transmission was not that evident due to the fact the magnitude of the process was transferred from individual to individual in a asymptomatic way, or we have a source of infection with a greater magnitude that generated people that have this source of exposure move to other countries, and that's where signs and symptoms of the disease start to appear. The characteristics of this monkeypox have some specificity because it's not the traditional presentation way that we have with the, and we see that the manifestations are quite benign, and they induce with some diagnostic precision, having the possibility of confuse it with other sexually transmitted diseases. So within the strategies that we need to confront this problem, we need to reinforce this component of the training of the healthcare professionals, guaranteeing the access to information, undoubtedly the communication media, without generating a conflict in terms of the access to information. It was suggested not to massively implement vaccination strategies because we do not need to expose everyone to a vaccine, but only the risk groups, healthcare professionals that might be exposed to endemic areas, or those lab specialists that are working directly for the virus. So thank you so much, Dr. Gotuso, for this fantastic lecture you shared with us. And I would like to know if there's any question. We would like to ask you to join us for a few minutes. We would like to thank those who are connected. We would like to thank you for joining us from the Ministries of Health of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. Last but not least, we also have participants from different English-speaking communities, members of the organization, and also individuals that are interested in knowing a little more about this disease. We would like to ask you to follow us on Twitter, Instagram, LinkedIn, and also in YouTube channel. This is a conference that is simultaneous, that has simultaneous translation, so you can have access to evidence-based information, and we can work together against infodemia or infodemics with fake news. We will do a very brief active pause, and we will now reconnect to have the Q&A. We will have a little physical break that will help our mind and also our body. Please share the video of the active pause. Thank you.
El organismo andino incentiva el bienestar de quienes nos acompañan.
The Andean Organization of Health promotes the well-being. Wherever you are, welcome to this physical activity. So from the Andean Organization of Health, the Hipólito Unanue Agreement, we invite you to take this action. Please use a piece of paper. So I hope that this is a recycled piece of paper, and you can shape a little ball of paper, and you start to make a little ball, passing it from hand to hand. And we will have Bolivia, Chile, Colombia, Ecuador, Peru, Venezuela, and we are working together from this agile activity to stretch our muscles. And with this anti-stress ball, you will throw it to the ceiling, back and forth, and once we dominate it, we will launch it, clap, and take it back. A generous movement to stretch our muscles and keep our mind busy. And now that you domain this first clap, please do 2 or 3 claps. 1, 2, 3, 1, 2, 3. If the ball goes to the floor, it's not an issue. You pick it up and start over. And we will see what's the record, how many claps you are capable of doing. Count, 1, 2, 3, 1, 2, 3, 4. Who's having the record of claps? As much as possible. This is the attitude. Positive energy. Fantastic. So we have 4 or 5. That's my record. So we can also do an additional exercise of throwing the ball, touching my head, and 1 clap. Do you have coordination? So that's the coordination strategy. Head, shoulders, ball. Head, shoulders, ball. I would like to know who are the most coordinated individuals from the group. So we will have a third exercise, and now we will do head, shoulders, and clap, okay? We will combine both exercises, head, shoulders, and clap, and see how we do it. It's possible, right? Yeah, domain development. Work with me. You can do it. Please, share your energy. Don't throw the towel. That's the attitude. 3, 2, 1. Fantastic. This is the last one. Fantastic. How coordinated we are. Okay, are we doing good? Fantastic. Throw the ball. We will do a little clap, and I will do it behind my back and pick it back. Okay? Are you ready? I throw it, clap back, and again I pick it up again. It's possible. Fantastic. Domain this movement. It's easy to do if you practice. How many you have done? 5, 4, 3, 2, 1. Share your energy, and now we can rest. How about if we do a clap in the front and a clap in the back? Just try it, okay? Don't throw the towel before you start. Back and forth, it's possible, okay. Positive energy for everyone.
Muy bien, 2, muy bien, 1, último, y acá, la pelotica. Esa es la intención, esa es la actitud. Bueno.
That's the intention, that's the attitude. So I see that our countries are working together with the coordination from the promotion of healthy habits. It's important to do it. Last exercise. I would like to ask you to take your ball, and now we will do this. You will leave the ball, you will hit it with your quadricep or your knee, and you will try to keep it in the air. Throw it, hit it with your knee, and hand it back. You domain the right leg. I will ask you to try it with your left leg. Okay, one back and forth, back and forth. Fantastic. Knee, and I will leave this exercise for you, for everyone from the Horas column, to work the coordination, agility. Okay, dynamism. 3, okay, 2, fantastic, 1, and rest. How do you do it? Fantastic, right? An exercise to release the tension of your body. Smile. stretch your legs, stretch your hands, stretch your back, and we release the tension. We fill our body with positive energy, and then we go to the other side. Fantastic. And breathe, always breathe. Don't forget to breathe. It's extremely important to breathe. Stretch, 3, 2, 1. I go back to the center. Breathe in, breathe out, and put your arms back. Some heat, energy. From the Horas Como, I would like to thank you from the bottom of my heart for joining us in this active pause. And we would like to invite you to keep doing these exercises in an active manner. And the organism of health. Police non-agreement. A deep salute for everyone.
Muchas gracias. Ha sido una pausa activa muy saludable.
It's a very active pause. So to begin with this dialogue from the question by our participants, I would like to ask you, I will ask Dr. Eduardo. I would like you to open your camera.
Estoy listo, Luis.
Bueno, acá hay un listado muy interesante de
We have a very interesting list of questions. And we will have three countries, three questions for every country. The first one, what are the most vulnerable population for contagious? What are the main preventive measures? What are the pandemics? What are the strategies that we can take from the COVID-19 to control the spreading of this outbreak of monkeypox? The third question, what are the organs affected by the virus? Is this disease generating any secondary effects?
Muy bien. Hay tres preguntas.
Okay, we have three questions. The vulnerable population of this outbreak were mainly men who had sex with men, or the gay community due to this physical contact. Women are not that frequently recognized in this outbreak, and we don't have any children cases. So the most vulnerable groups are this particular population. But of course, if we travel to Africa, we need to know what are the diseases that you might be exposed to. The Democratic Republic of Congo, Cameroon, Nigeria have a small number of cases. So there, the contact with animals might be risky. I might say that the animals from Latin America are not infected, and we don't have those rodents present. So it's something that I would like to mention. In case of the preventive measures, to recognize that individuals that have sex with other men have to recognize or to have to be aware of cutaneous lesions, or to prevent infectious or contact with other men when the cutaneous lesions are present. This is something that we have to take into account with practice of safe sex. That is an important component. This is a disease that is transmitted to this cutaneous contact. Small vesicles are the source of infection. The respiratory transmission is quite minimal or infrequent, but the healthcare participants have to use masks. The patients with this disease will also need to use masks, face masks, but the respiratory spreading of the virus is quite limited. We need to insist on the experts might be the final word, not the social media that have 90 or 80% of fake news that will generate fear or panic And it's a fundamental lesson. That's why our countries are not finished vaccinating. We suffer from a scarcity of vaccines, and now we have the vaccines, and unfortunately, the vaccination areas are completely empty. When we have 30 or 35% of the population in Peru that is unvaccinated. So I might say that this is an effect of the fake news that damage our strategies. The organs that are affected are actually the skin. Some patients also report some oral cavity lesions or orogenital lesions, and the virus could produce meningoencephalitis. And people used to die to the spreading of this virus where the central nervous system is affected. And also the pulmonary and systemic condition are important. So those complications didn't happen in that spread. So patients that present these lesions were following this benign course of the disease from the mortality perspective, and thus that will be my answer to these three questions. So here we have other three. Can we discard the smallpox with patients that are already vaccinated or with previous infections with smallpox? The second one, do we know any cases of monkeypox in children and adolescents? Based on your consideration, this is the third one. Can we consider the monkeypox as the HIV of 2022? Thank you. First of all, about the sequela. The sequela are mainly cutaneous, like little scars that we used to call them the erased, the ones that are having so many lesions on the face that they were like little holes that looks like a background of smallpox. When the patient scratch the lesions and leave those scars for the rest of their lives. We have not detected children and adolescents in this outbreak, but in the African countries, we have detected this spreading into children because they are the ones who go to the jungle and they capture these wild animals and get the infection. But about this outbreak that is mainly attributed to adults that are exposed to sexual intercourse. And of course, we cannot say that this is an HIV country, an HIV outbreak, because unfortunately the HIV comes from the uterus or in lesions from the genitalia. But it's important to differentiate, but because the individuals that have HIV and they infected others are not aware of the fact of their disease, and that's why the pandemic grow so much and very fast, and that's why that up to this moment, this disease is affecting the situation of the emergence. So it's not a condition that might have the characteristics of being a new COVID because it's not transmitted through air or sexual intercourse, but in particular sexual practices between men to men. And there are many parasites, staphylococcus infection when we have a close contact from, for example, there are some staphylococcus that happen with sportsmen that play American soccer or American football or Greco-Roman fights, and they were infected with staphylococcus. And this is not meaning that this is an epidemic. It's not COVID, it's not HIV, what we are seeing right now. This is a very important lesson to be learned, and that's why we decided that we shouldn't be planning a vaccination strategy for all the population, and we do not to purchase million vaccines for that condition. This is not the future. I am basing my opinion on how do we transmit And that's how we can answer. For those who suffer from smallpox or were vaccinated, up to now, we recognize that almost 90% have antibodies against this virus. And it's possible that the other 10% that do not have the antibodies still have some defense active. And I would like to briefly explain it. In vaccines against yellow fever, we have vaccines every 10 years. And when we analyze it, we see that 90% are having antibodies still. But those who are not detecting the antibodies, we are already protected because we have another system. The mechanisms of defense have the serological component of antibodies, but we also have what we call the T cells. And these T cells are not measured in the day by day. This is a very technical and sophisticated topic, a more expensive topic. This happens also with hepatitis B, because after some years they are still having antibodies. And the ones that are not having antibodies, they are still protected because they have another component that is present. So it's possible that almost 100% of individuals older than 50 years or 55 years, depending on how long ago they were vaccinated, are protected, and the ones who have smallpox or other viral diseases will not suffer from that again. And that's why these individuals are protected to exposure of this virus or monkeypox. Thank you so much, Dr. Gotuso, for your answers. Before I continue or moving on, I would like to say that they are very good questions, and I would like to extend my gratitude to all the participants' country, Angola, Argentina, Honduras, Cuba, Mexico, Paraguay, Germany, that is also participating into this event. One specific question is the following. Do we need to extend our genomic surveillance for every transmittable disease as a program, a horizontal program, a dynamic program, instead of focusing on each disease? The second question, the situational rooms that were created for COVID, should they work for any other emergent condition or re-emergent conditions? And third one, as you already explained, this outbreak come from the problematic of traffic of species outside their natural areas. So what are the international measures that could be recommended to control this particular source? What are other policies that might be needed in our countries to prevent the zoonotic diseases? Well, first of all, I would like to start with the third one. I might say that humanity grows a lot. We are more than 7,000 million individuals, and we need food. One of the things that every culture do, especially the poor areas, is moving to the closest areas and use them as part of their feeding practices. And up to now, then is very good. But there are some animals that we do not know, and there's a lot of diseases that might move to the human beings. So the first thing that we need to do is the surveillance of zoonotic condition. That is 1/3, that represent 1/3 of diseases of the human beings. It's extremely important, of course. One single health as an educational concept for physicians, for the health staff, are quite important. And the second component are the transportation norms. In Peru, for example, we are a huge transporter of animals for different zoos in the world. Many pets that came from jungle, such as salamander, small dragons. Many salmonellosis came from these small animals. So there are many conditions that might be produced by pets because they are quite good for improving our state of mind and to be relaxed. And they are, of course, needed in our lives as pets, and also, but there need to be very clear and strict norms to transport live animals to reduce zoonotic spreading of virus. And of course, we need to include as well some traditional aspects. The genomic studies are quite expensive, but of course are extremely important when we study the genomic of microbes, for example. The luck we had with the pandemic of COVID is that both in China and in Taiwan and other countries, the coronavirus were studied. So when we have the Wuhan version, for the third week of January, in less than 1 month, they already have isolated the genome, and that genome allowed the pharmaceutical companies to create drugs and vaccines. So before 6 months, we already have clinical trials running using new drugs that were completely new, because we already knew the genome of those vaccines, and we know that the genome that we have right now that comes from Nigeria and not coming from Congo. So when we make decisions, the experts should look this information, how much mortality we are looking for, how can we reduce that mortality rates, and the study of genomes, of course, are the future of the medicine. And I'm sure that we have to strengthen that. Unfortunately, we have to look for systems that will be more affordable for our nations. And let's recall that every emergent or re-emerging condition has a mechanism of transmission that is different. If we talk about resistant tuberculosis, this is a condition. If we talk about the monkeypox, it's another condition. And we talk about the contamination of metals, illegal mining. We can talk about an additional problem. It's an emergent condition. They have different approaches. And we need to strengthen our surveillance strategies. And we need to talk about expert groups. For example, during the pandemic, the entire country needed to do tests for COVID, but the norms didn't allow that to do so. And we have experts in the labs that were available to do the tests. So we have to create that spirit of cooperation, knowing that we have to work together. In the government and the academic group, to do frontal decision more than a situational room. We need to create groups and be ready to future pandemics due to food contamination, through airway, or to mosquitoes. We need to be ready to detect, because as Dr. Calle mentioned, the climate change is something that is affecting us very deeply. And that means that we will have particular outbreaks because we have focus of areas, and climate change is not something that might be considered theoretical, but it's something that affects the entire humanity. Recall the cholera epidemic is one of the model of the climate change. And we need to keep in mind of international cooperation. The role of the health staff is quite important. Molecular biologists, the nurses, the physician that is looking for intensive care units.
Grupos de trabajo permanentes, mirando enfermedades emergentes y reemergentes.
Muchas gracias.
Analyzing the emerging and re-emerging diseases. Thank you, Dr. Gotuso, and to respect the timeline and your knowledge. And I would like to to close with these two last questions. The first one says, in front of this monkeypox outbreak, what are the strategies that we have to implement? What might have a profiling of the Andean region? Do we need to create strategies of bioprotection or biosecurity measures? What are the implications of this particular outbreak? So what are the most effective strategies to inform the high-risk populations? Can we learn from other conditions such as HIV or COVID-19? I will start with this last question. I recall that when we started to see the pandemic of HIV, we see this need of promoting the use of a condom. Peru, unfortunately, was one of the lower rates in sexual intercourse with sexual workers. 5% in Japan was almost 90%. So when you spread the message of the sexual workers have to be protected because you are going to be sources of contact, that never changed. We educated sexual workers. They assume the training of peers, and I recall that a young one very early become a leader. And she turned into an employee of the Ministry of Health, educating other sexual workers. And this is a strategy that was promoted by the University of San Marcos. And we receive a lot of support, and that make it in 5 years, the usage of condom increased from 5 to 95% in sexual workers from different areas of Peru. By surprisingly on the streets that we have clandestine sexual workers, the information was also available. So these individuals were fundamental. I also work with the MOL, the homosexual movement of Lima, to teach them how to take care of themselves. So we start to discuss about safe sex. So we learn from each other. Without creating stigma. So that's important to take the time to do that discussion. And the problem of having that we have in Canada, the Canary Islands, in these meetings that we have we could not ended up saying that they break the biosecurity measures because they could get infected or infect other people. And we need to educate them because they are risk groups without creating the stigma. This is a very important question because this is the way of becoming effective. Because if we started to say, well, the homosexuals need to be isolated, that will never work. It's mood and it's quite because everyone will have the possibility of choosing their own sexual orientation, and they shouldn't be discriminated or create a stigma behind their sexual choices. So it's important to train them. If you are an alpinist, for example, and you do a risk sport, you shouldn't be trained to be safe for them, to use a helmet, for example, or different elements of protection. This is what we do. And the same thing should happen in the health of this individual. We need to work with the different risk groups and train them so they could have access to the safe measures, safety practices. And what happened in the Andean regions? Well, the first thing that we need to do is to measure the impact of the disease. Because, of course, one case might be reported in Peru. Sooner or later, we will have a case, but that wouldn't mean that we will have the epidemic present. Of course, these cases could be isolated. We can make epidemiological analysis. So if we have an outbreak, we need to isolate the patients to study them and to know what happens based on the experts' opinions. And now the epidemiologists in Peru, we have a lot of training. The National Vaccination Program is an excellent initiative, going to the most distant areas or going different areas of the Amazon rainforest to vaccinate. So I might say that we have a series of instruments that we need to take into account. The meritocracy, the health sector is fundamental. That's why I say that if we have an outbreak in Andean area, we need to call and to see what's happening and to follow the regulation of the WHO. What type of virus we have? The genome, in 48 hours, we have a response. So again, I think that these regional measures of this outbreak should make an epidemiological circle of closing this situation, of covering all the potential cases and try to isolate them until the individual is not infecting others. In smallpox, we know that we see when the pustules fall, it was the infection phase, and the same happened with this smallpox. So I might say that this is what the experts share with us, trying to create a program to give the option of a quick response in front of these cases. But let's not get scared if we have one or two cases. It might happen. This is not represent an epidemic or start a new pandemic from 2020. So that will be my answer, and thank you for the opportunity that I received for having the opportunity of sharing this with you to improve the health of our population. Thank you, Dr. Gotuso. We are extremely happy of receiving this information and the time you have dedicated to share your knowledge with our colleagues and the experience you have to fight against this public health issue. We would like to thank all the participants that week after week work with us from the team of Horas CONU and every single participant of this activity that was possible thanks to the commitment and the Andean integration. And to close this session, I would like to invite Maria Carmen Calle, Executive Secretary of the Andean Organization of Health. Please, Dr. Calle. Thank you very much. I would like to thank Dr. Eduardo Gotuso for his fantastic presentation, for the availability of answering the questions that were made. I would like to thank the Andean Organization of Health with Bengalea for the preparation of this webinar, and quite especially thanking more than 300 participants that were participating today. I am quite happy because we were doing the interpretation to English 4 weeks ago, and right now we are having a lot of participants from English-speaking countries because we consider that the information that the Andean region of health, the Andean health organism is based on scientific background, and we need to listen to the experts. And with that evidence, we can make steps forward. You know that the webinars have this follow-up. We will then have a technical meeting with the experts, representatives from different groups. We have now the immunization committee, we have the public health committee, and the representative from the 6 countries will be able to discuss these topics because this is a priority. And that's why we decided to do an extraordinary meeting of Ministries of Health, and this topic was discussed. One of the most concerning aspects was biosecurity and that early detection. And we are taking some resolutions to follow this in comprehensive work that is improving little by little in our 6 countries. My comment to wrap up is that the information was very clear. We are not in front of the possibility of a pandemic. This is a zoonotic disease, more prevalent in men that had sex with men. The priority measures will be to teach the population to take care of themselves. And if we detect one case, we need to isolate them. We also have the possibility of doing an early diagnosis. Our institutes are trained. The mortality is 1%. I might say that is not that high, but of course, every single life has to be protected. Let's not be scared when the first case appear. We need to take in a very special manner to the media to avoid misinforming the population, inviting the experts to talk about this topic to avoid the infodemic or alerts. Another aspect that we need to discuss with Dr. Gotuso, it's extremely important to discuss, is a topic that we are now dealing with around the globe in terms of equity, diversity, and inclusion. We cannot use this disease as an stigmatization media to those populations that will be more vulnerable than others. So the fact that it's more prevalent in men that had sex with men didn't mean that we as the health organization will stigmatize those individuals. So we have to work so every single individual that lives in our 6 countries will have the right to access to health, reducing inequalities. Because when we talk about inequalities, we also talk about individuals that will be more vulnerable in our healthcare professional position. As Eduardo said, we don't have the right to judge. We need to accept this is a profession that we need to accept because it's a profession of service, a profession that needs to be practiced with science, art, professionalism, and care. We will meet again the next Thursday to talk about alcohol and other drugs in relation with the pandemic of COVID-19. Thank you very much, Eduardo. Thank you very much, Lucho. Thank you, everyone, for joining us, and good afternoon.